Hello, my name is Rhonda Dickman. I'm a registered nurse and clinical quality improvement specialist with Tennessee Hospital Association. I am honored to lead THA's Sepsis Collaborative, a group of hospital representatives from across Tennessee who are working together to reduce sepsis mortality. One of the leading strategies promoted by the collaborative is implementation of the sepsis bundle as outlined by the Surviving Sepsis campaign. While some elements of the bundle are controversial, one element is emerging with additional evidence in its correlation to mortality, and that is time to antibiotics. In this brief presentation, we will look at time to antibiotics correlation with sepsis mortality, as is demonstrated in 5 recent studies. In a single center observational cohort study, of 117 patients admitted to the ICU with sepsis or septic shock, Kim and associates, after adjusting for expected mortality, found a 22% increase in mortality risk for each hour delay from triage to antibiotics ordered, and a 15% increase in mortality risk for each hour delay from triage to antibiotics given. Liu and associates, in a multi-center retrospective review of 35,000 patients with sepsis, severe sepsis, and septic shock, found adjusted odds ratio for hospital mortality that was based on each hour delay in antibiotics after patient registration to be 1.09. And when they evaluated this pattern across the 3 strata of sepsis, they found it was present in all 3 strata, but especially so in the sickest of patients, those with septic shock. Seymour and associates, in a multi-center retrospective review of over 49,000 patient records with sepsis or septic shock that had received the 3-hour bundle within 3 hours, found adjusted odds ratios for hospital mortality based on each hour delay in antibiotics after patient registration to be 1.04, very similar to the findings in Liu's study. Hoffman and associates went a different direction. In this multi-center review of 459 adult patients treated for severe sepsis or septic shock with the sepsis bundle in the ED, ICU, and wards, compared median time to antibiotic between patients that survived and those that expired, and found a significant difference. They state there's a statistically significant association between time to antibiotics after declaration of severe sepsis or septic shock and mortality, even within the prescribed 3-hour time frame outlined by current Surviving Sepsis campaign guidelines. Lastly, Pelton and associates, in a multi-center retrospective review of almost 11,000 non-trauma ED patients with clinical sepsis, found a long-term impact associated with time to antibiotic. For each additional hour from ED arrival to antibiotic initiation, they saw an associated 10% increased odds of 1-year mortality and similar increased odds for hospital 30-day and 90-day mortality. As hospitals consider this evidence and other evidence on antibiotic timing and give thought to implementing a performance improvement initiative in their facility to shorten the time to antibiotic, a common question emerges, and that is, what about antibiotic stewardship? If we work to shorten the time to antibiotic, will we be promoting a rush to treatment that could cause harm? The Society for Critical Care Medicine tackled this topic in their 2017 46th Critical Care Congress with a panel discussion of physicians from the Society for Critical Care Medicine, CDC, Infectious Diseases Society of America, and the American College of Emergency Physicians, which is recorded and available for viewing on YouTube. The conclusion of the panel was that the risk-benefit ratio favors treating, and that the antibiotic stewardship problem in our nation is not so much the sepsis patient in the emergency department who's receiving a broad spectrum. However, because antibiotic stewardship is very important, they offered the following recommendations. First, every organization should establish a strategy to help providers with antibiotic selection, dosing, and de-escalation that has multi-stakeholder input and is easy for providers to use. Focus should be placed on good specimen collection prior to antibiotics to help inform future antibiotic decision-making. When hospitals have viral detection systems in place, those should be utilized. Obtaining a good patient history and assessment may help make decisions about antibiotics, and antibiotics should be given in the right type and the right dose, again stressing the importance of a clear and easy protocol. Lastly, they stress the importance of re-evaluating antibiotics within 24 and 48 hours for adjustment or discontinuation, and stressed that this was the place where true antibiotic stewardship in the sepsis patient takes place. In summary, time to antibiotics correlates with sepsis mortality in multiple studies in different geographic settings, and early treatment with antibiotics in sepsis patients can occur within a strong antibiotic stewardship program. The THA Sepsis Collaborative recommends that hospitals thoughtfully consider programs to reduce time to antibiotic as a leading strategy to reduce sepsis mortality.